to Dallas Weekly's special health edition here in April, which is Minority Health Month and STD Awareness Month. So we are now speaking with doctors from Parkland about some of the concerns of health disparities and issues going on in the African American community, especially during the time of COVID. And today we have HIV/AIDS. So we have doctors Amneris Luque, the medical director of HIV services at Parkland Health and Hospital System and professor of infectious diseases at UT Southwestern Medical Center, and Dr. Jacqueline Juarez, HIV therapist of Parkland Health and Hospital System. Thank you both for joining us.
Thank you.
All right, let's sort of take it back a little bit and just prime our audience for, so what is HIV and how is it related to the AIDS virus? And feel free to, jump in, whoever wants first.
HIV stands for Human Immunodeficiency Virus, and that is the name that was given to the agent that causes the disease. Now, HIV goes through several stages. One will be the acute phase of HIV, the first time the person gets infected with the virus. And about 50% of patients will have some kind of symptoms with that, like the flu, but a little bit more intense. Not everybody seeks medical attention for that. And when that passes, it could last up to 2 weeks or so. Patients feel perfectly fine, and for many years, 8 years, 10 years. And then their immune system, of course, during this time is suffering because of the virus is actually attacking some of the most important cells that defend us against other diseases. And so as these cells decrease in time, then patients are gonna get sick. And they're gonna get sick with unusual opportunistic infections. And that is what we call AIDS. So this was the term that was first coined because in the first years of HIV/AIDS, patients will present very late and they would only live for a year or a year and a half at that time because we didn't have medications that could offer them improvement. So AIDS was the first term. There is a classification of AIDS if the person has CD4 cell count of less than 200, because that is the dangerous level of those cells in the immune system. And that's what leads to having what we call opportunistic infections. So these are infections that usually do not occur in a normal host, a normal person that doesn't have any problems with their immune system. Also, if a person has had one of those infections, they are considered to have had AIDS, but people recover from that AIDS stage now with the current medications, and they can live a normal lifespan, which is wonderful to see.
Okay. And do we know where HIV came from? Yeah, I mean, there was a lot of rumors, obviously in the 80s, obviously in the 90s. Have we locked down or at least have some more understanding of where HIV came from?
Yes. This virus is one of those viruses that jump the species. So it has been isolated from the common chimpanzee in Central Africa. And it turns out that this chimpanzee may have got it from other monkeys, from Suti Mangabi, because it seems to be that it's a combination of viruses that are found in lower primates. But it is thought that it came to the human race because there are individuals that like to eat meat from these particular chimpanzees, including the brain. They slaughter them. And so blood splashes could have been the reason why people got contaminated, or just eating the meat from these animals. So that's how everything seemed to have started.
Okay. And let's speak a little bit more about the modern HIV/AIDS epidemic. As we all know, the HIV/AIDS epidemic kind of gained popularity isn't a great word, but gained notoriety in the early 80s and kind of sort of stayed stagnant. And now we see it being brought up in comparisons to things that we have going on now. Is there any comparisons to the COVID-19 pandemic and the HIV epidemic of the 1980s?
Okay. Well, both are public health crises. And I think that's the biggest similarity that I find in that, because they are transmitted very differently. HIV is transmitted by sex, by sharing needles, mother to baby transmission, or through breast milk, unlike COVID, that is transmitted with close contact and aerosols and those kinds of things. So there are big differences. Unfortunately, for the HIV part of things, we didn't know the agent causing the disease for at least a few years after the first cases were described in 1981. For COVID, very rapidly, we knew the whole genome of the virus. And now we have a vaccine that is very efficacious in preventing COVID, especially serious disease, hospitalization, and death. And we still don't have a vaccine for HIV. So there is a lot of differences. When you look at the political arena, there were some similarities there because there was a little bit, people were afraid when HIV was first described and when it was associated with sexual minorities, that they didn't want to touch that because it had to do with intimacy, with sex and other things. And there was very little that the politicians wanted to address at that time. Mm-hmm. And then obviously celebrities came out as to having HIV, and that started to change things. And then when Ryan White, the young guy that was a hemophiliac, became public that he had acquired HIV/AIDS through a transfusion, then that was a tipping point. Things changed quite a bit, and it was understood that this is something that can affect anybody. And there was a lot of pressure because there was a lot of activism during that time through ACT UP and others that were pushing for medications, from guidance from the CDC and other bodies. So at that time, people were also very concerned that the institutions, the government and other institutions were telling them what to do. Like, do not have sex, or you have to use condoms. And that's a little similar now. There are people that feel that their freedom of speech and action is being curtailed by the government telling them you must use a mask, you must do this, you must do that. So those two things are similar. I think there is always, when there is fear, there is also reaction to that. And that is probably what is happening, the baseline for that is, or what's causing that. So that's really it. Well, there have been a lot of people affected, and that's similar. A lot of people, including young people, that have died with both diseases. But with COVID, it affected more individuals that were elderly, especially at the beginning, which is a difference. So what I can say is that being a public health crisis is the biggest similarity that I find in both of them. We have now better look at viruses and do testing. We didn't have testing for HIV for 4 years at least. So that's really different.
Okay, and let's talk about where we are with the treatments. Before it was considered a death sentence. And as you just mentioned, that people can live good lives and, live effective lives. What are some of the new treatments that have been used? I've heard of something called PrEP and some others. You can tell us, our audience, a little bit about what happens when you get HIV now.
Okay. When you get HIV, first we have recognized the need to start treatment very quickly. Why? Because this is one way to secure the immune system will be intact. It's easier to recover an immune system that is not already so damaged by the virus. And very importantly, When you treat a person with HIV with medications and they take their medications, they can become what we call undetectable, meaning the amount of virus in their blood goes down to undetectable levels by the lab, and that prevents transmission to other people. So as we call it, treatment as prevention. So treating individuals soon after they know that they have HIV is what we're doing these days. We call it rapid start. And it's very important because it's going to help us decrease transmission to others and decrease number of cases, and also preserve the health of the infected individual. PrEP is a little bit different because PrEP, even though it stands for pre-exposure prophylaxis and includes medications that are the same we use for treatment, but fewer, instead of 3, 2 medications, is to be given to individuals who do not have HIV, but who are at risk of getting HIV. And if they take these medications, it will prevent them from acquiring HIV. So PrEP is another very important strategy to try to decrease cases and keep people healthy.
Okay. And I think I want to speak about stigma a little bit. It's been told to us that, if not the number one of the leading causes for the HIV spread during the 80s and 90s was stigma. And is that still a leading cause of people not getting tested or understanding HIV? And if it is, what can be done about that? I think Dr. Juarez, I'd like to hear from you.
Well, thank you for having me, Patrick. And just to clarify, I'm not a doctor, I'm a licensed clinical social worker, but thank you. I appreciate the additional add to my credentials. You never know, someday. But on stigma, this is something that I think we are working so hard in this community to help break down, because yes, it absolutely does cause people to not get tested, to deny that they have tested positive and maybe not seek treatment, not take medication. I've heard that from several patients. Once they've tested positive, they can't believe it and can't imagine what it's going to be like to have to tell their family or friends or sexual partners. And so oftentimes that stigma, the fear of having to confront that diagnosis and what the treatment means and what that means for them, oftentimes does lead to falling out of care, unfortunately.
Is there anything that can be done about that? Like, is there any kind of awareness, or is there any practices that have shown effectiveness in breaking down stigma?
Absolutely. So the number one way to combat stigma is with talking about HIV and seeking information, really to learn about the disease and disease process. One of the things, even now, I mean, we are many, many years from the first reported case of HIV in the United States, yet we still have individuals and family members who believe that HIV can be contracted through saliva. So they fear kissing a family member, or believe that HIV can be contracted through shaking hands, for example, or sharing a toilet seat, things like that, we know are not risk factors. And so education is the first one, absolutely. Ask questions, but don't seek the answers from somebody who's newly infected. Try to find those answers online, seek out advice from physicians. One thing I've also offered to patients that have tested positive and maybe they have a supportive family member that doesn't know what to do is ask them if they'd like to attend a doctor's visit with them, or help them maybe write down some questions. What is it that they don't know and would like to learn more about?
Yeah, and it's like Dr. Luque said, so a person then knows they have HIV and then has this issue, right? They don't want to speak about it. And let's talk like that particular hindrance for the Black community, because we also have some resistance to, mental health issues and other things. So how, one, in your experience, is the African American community affected by this stigma? And two, is there are any of these practices showing positive effects within the Black community?
Yeah, absolutely. And so I think to get to your first question, really, you absolutely hit the nail on the head. There are some unfortunate cultural beliefs within the African American community that believe that if you are seeking any sort of mental health services, talk therapy outside of the home, then you are committing some sort of affront to the family unit. Oftentimes, I'm Hispanic, but even in my childhood, I heard what happens in this house stays in this house, right? Because the cultural norm is that we are going to take care of what's happening here. And sometimes it's mistrust of the medical community for good reason. It's mistrust of not understanding what talk therapy includes, the idea, the fear of being labeled as crazy, for example, the fear of being labeled as something's wrong with you. And not knowing how to seek out that help. So that's absolutely, I think, one of the biggest drawbacks that I think happens within the African American community. One of the ways that I've seen it being combated and confronted in a really positive way, we do this a lot in our clinic at Amelia Court, is we have a behavioral health therapist on site, and that's me. And if I have the availability, if a physician has a patient that's newly diagnosed and they want me to just meet with them, to do just a warm handoff, hi, I'm here for you. If you need to talk about this, if you want to talk about this, you want to gain more information, you feel like you need support, here I am, here's my phone number, give it to you on a business card, we can make it as discreet as possible, or I can set up a visit with you right away. I find that type of warm handoff, that immediate attention, to be one of the best ways to combat some of those fears, because it puts a face and maybe even just a warm demeanor with to kind of combat those negative beliefs of mental health care.
Okay, and stop me if I'm wrong, but it sounds like in the past 30 years of HIV/AIDS research and all that stuff, we've gotten to a point where we can treat the virus to a certain degree, but there are some pretty big hangups psychologically in people. Like there's a jump from HIV to depression, like what is that? And how is that being addressed within specifically the African American, but just, in general, as you just described, it's like people don't want to get in, they'll fall into these depressions, I would imagine. So is that something that happens? And if so, how do people, one, recognize that? And what's the industry doing to address it?
Well, I think integrated behavioral health is probably one of the biggest ways that we can combat that, because we know that most individuals, a good number of individuals with chronic illness, medical illness, oftentimes have a comorbid, meaning they have a concurrent mental health issue, and most likely it's depression, oftentimes anxiety as well. But there are other mood disorders, cognitive disorders that can also co-occur. And so we see a variety of things, individuals that come in with some mild to moderate depression, fearful about what this diagnosis means to them. And then we see individuals that have long-standing histories of trauma that's never been addressed. And have they dealt with that has been maybe through maladaptive coping skills like drugs and alcohol use, high-risk sexual behavior, multiple sexual partners, not following up with their own medical care. And so then oftentimes that leads to contracting STDs, HIV being one of them. And so we see these patients come in and they're already presenting with some depression, some mild to moderate depression. So having somebody in the clinic that's able to address that, maybe even just do a quick phone call to check in, is really, really powerful, and it's really helpful. What we find is that if we refer patients out to community healthcare facilities and community mental health specifically, oftentimes if those issues are underlying and maybe they've been there for quite some time, our patients, because they're so overwhelmed, may not seek the services when those services are offered.
Okay, I want to do one more about the stigma, then get back into some of the clinical stuff, specifically with the African American. A few years back, I'm sure you've heard, we had a big conversation going on about this whole DL lifestyle.
Yeah.
And I feel like that fits into stigma. Yeah. Has that changed at all with for those of our audience who don't know what DL is? It was a experience of some men who either were denying their sexuality or, just acting on certain sexual instincts and being irresponsible, and then being in heterosexual relationships with women and passing HIV to them. It was a pretty big topic in the late 90s into the early 2000s. And as we were dealing with our HIV series a few years ago, it came up again from the Health and Human Services department. They said that is probably a big thing. I want to know if that's still a thing, because we have not huge steps, but we've moved a little bit with the acceptance of LGBT communities and people. Has that at all stopped, or stopped is a bad word, suspended a little bit the numbers of African Americans contracting HIV through this particular experience?
Well, I can tell you through what I'm seeing in our clinic is that unfortunately it hasn't stopped, and we don't see necessarily a complete kind of cease in that behavior. I think we still have to do a lot of work on stigma. You know, I'm not sure exactly what the numbers are of people self-reporting how they contracted HIV, if they were on the DL and they were living a lifestyle that was not necessarily out in the open, or if they, you know, had open communication with a partner. But I can tell you that we just recently completed a 3-year project at Parkland where we specifically looked at African-American men who have sex with men. And we were very careful about utilizing that subgroup because not all men who have sex with men identify as gay. And so what we found is that as long as, you know, those patients were connected to care, they had the appropriate services like our peer navigation services, and they had reminders to come into clinic, and we talked about, you know, any mental health needs, that they were having pretty good outcomes. But it's a small subset of people when you look at the larger grand scheme of things. So still education needs to be done. Peer support is something that's extremely important to, you know, even providing support groups in ways that can help men who have sex with men that don't identify as gay, help them to come to terms with whatever it is that they're grappling with, and open lines of communication with their partners to not put them at risk as well.
Oh yeah, okay. And I would like to remind our audience that if you are interested in what some of these stories have developed as, we do still have our series Love After HIV, produced by Carla Davis, which talks about people who have contracted HIV and moved on to have relationships, families, etc. So please look at that if you are thinking that this is something you're interested in. Dr. Luque, I'd like to get back to the HIV/AIDS virus as it sits clinically. So we all know what it is now. What are some of the symptoms? Like, how can somebody recognize that they may have HIV?
Okay. HIV in the chronic stage has, at the beginning, very few symptoms. Maybe some weight loss, nothing much. That's why screening is so important, doing an HIV test for everybody and repeating that test for people who are high risk. Now, during the acute phase of HIV is when we see some of those symptoms such as fever, fatigue, which is actually very pronounced. They can have sore throat. They can have a rash similar to rash that is caused by allergies. And occasionally they could have meningitis or a lot of headache that is not relenting with regular over-the-counter medications. And some have actually have one of those serious opportunistic infections during acute HIV, but it tends to be very treatable, and they recover, their immune system recovers, and then it's kind of a honeymoon period. And if they get untreated, they will continue to deteriorate over the years. Now, as the disease progresses and somebody doesn't have treatment, weight loss, diarrhea, memory issues can be all symptoms of HIV. But most of the time, and this is something that happens a lot in the South, that is the late presentation of HIV. People who have symptoms, but they don't see a physician or any other healthcare provider for their symptoms. And they wait and then develop one of these serious infections, such as histoplasmosis or pneumocystis, and then they get admitted to the hospital seriously ill. Some of these infections can be fatal, such as meningitis, especially when it's produced by a fungus. On occasion, they're all treatable, but patients may react poorly to medications, develop toxicity, and that may interfere with our ability to kind of turn things around for them. So it's really important for people to get tested, everybody ages 13 and above. CDC puts limits of 64 years of age, but there's a lot of people that are sexually active beyond that age, and I think deserve to be tested just as much. We have a lot of seniors that have been diagnosed with HIV. And so they deserve to be treated like anybody else. So they should be tested. For those individuals that are engaged in high-risk behavior, that have multiple sex partners, that use sex without condom, that exchange sex for money or drugs, they need to be tested more often. Because if the behavior continues, they are putting themselves at risk.
And what HIV services does Parkland have to offer?
Parkland is a Ryan White funded clinic, and we have clinics in campus, the Amelia Court Clinic that is soon to be moving to the new Moody Outpatient Center, and 3 clinics also in the COPCs, which are clinics in the community that Parkland has. And through those clinics, we provide comprehensive care for our patients. That is administered for people who are dedicated to HIV. They are HIV specialists, and they provide the up-to-date care for their HIV. But we also are primary care for many of our patients, in particular those who only have the Ryan White coverage as insurance. And so we provide primary care. There is also, as Jackie mentioned, there is counseling available and mental health in the clinic. There is case management that could be medical case management or just social work case management for the patients, depending on their needs. We also have nutrition consultations and financial screening for patients to see if there is another insurance that they can opt for. And that's a very important function of the clinic. Also, Parkland is one of the biggest local entities where HIV testing takes place. And so not within the HIV program, but kind of in conjunction with, there is HIV testing that is completely free. It can be anonymous, and it's done in the premises. And there is also a special program that is funded by DISHES of HIV testing in the emergency room that tests a lot of individuals that otherwise don't have any other contact with the healthcare system. And it's a very important way of provide HIV testing to individuals. And also, if they turn positive, there is a navigator that connects them to services. Those are the most of the services. We also provide referrals to dental care, and that is also funded by Ryan White, but they admit any patient with whatever the insurance might be. That's very important because oral health is also one of the priorities for our patients. We provide treatment for other sexually transmitted infections, and we provide screening for that for our patients. That's pretty much it. I'm sure if I'm forgetting anything, I'm sure Jackie could help me out.
No, I think you got it all.
Okay.
And finally, Doctor, I just lost my question. How are we doing as far as Dallas County goes, HIV wise? Are we having more infections? Are we having less over, like, maybe let's say over the last 10 years or so?
Yes, sadly, this area is one of the jurisdictions with the highest number of new infections. Okay. And so CDC, NIH, and the Dallas Health Department in general are trying to decrease the number of new infections. And there are several initiatives going on to try to really decrease that, including the PrEP that I mentioned, that is really not, is underused. A lot of it is because of lack of awareness. A lot of the African American community do not have access to prevention education, and some of them don't know or have misconceptions about what PrEP may be. And it's similar for the Latino community also. And these are the individuals that really could benefit from them. There is more than 100,000 people in Dallas that could benefit from PrEP and are not taking it. So that's quite important to try to, if we are going to end the HIV/AIDS epidemic, we need to decrease the number of new cases. And either through treatment as prevention, as I mentioned, by treating everybody that is has HIV, and treat them to the point that is a consistent treatment that leads to being undetectable, and then prevention to those who are high risk.
All right. I guess finally, Jackie, I'm gonna leave it with you. What should the African American community know about HIV? What would you want them to walk away from this understanding?
That it's not a death sentence anymore, and that we can totally treat this disease. It is treatable, it is manageable, they can live a normal life. I tell this often to patients, especially my patients in the African American community. We know diabetes is pretty high in the African American community and the Latino community. If you were diagnosed with diabetes, would you not take the medication that you were offered because you just didn't want to take medication anymore? And oftentimes I hear, well, no, of course I would take it. It's going to help so that I can eat the way I want to eat, or, well, then we're going to think about this medication in the same way. These medications are going to help you live the life that you want to live. And it's no different in so many ways. So I would say that would be my biggest takeaway, is that know that there's help out there, know that there's education, know that there is mental health support, and that you can live a long life if you come up positive, you take the medication, and you go to your doctor's visits regularly.
Great. That was the positive uptick that I was waiting for. I want to thank you both again for joining us here. We want to thank Parkland for providing your time, or y'all for providing your time at Parkland, and your services in the HIV/AIDS spectrum. We really do appreciate that. And for those that are watching, we will be back tomorrow with more health content from Parkland doctors and associates. And we hope to see you then. Again, thank you both, and try to stay healthy, guys.
Thank you.
Thank you.